Hi, it's Dr. Noel Williams, July 9th, 2020, Oklahoma City, Oklahoma, Optimal Health Associates, COVID update. First, the statistics, none of them good. We're at about 18,500 cases in Oklahoma, 410 deaths, another about 650 cases, which just seems to be roughly our average day now over the last 6-7 days. So our case numbers are increasing, our hospitalization numbers are also increasing, our ICU beds are starting to get a little more full. Thankfully, the Integris people really got the job done and have the Deaconess campus, I believe, either open or just about open. A big shout out to everyone at Integris. But again, big shout out to everybody at all the Oklahoma City area hospitals, including OU, Saints, Mercy, Midwest City, and Norman. A great group of administrators, a great group of physicians, nurses, respiratory therapists, and staff doing their all. And remember, these people are once again really going to start putting their lives at risk. So keep them in your thoughts and prayers, because they're all going to need everyone's support as the stress levels begin to go up due to the case numbers. In the United States, we're at 3.2 million, I was going to look, but I think I can remember, about 133,000 deaths. World, 12,554,000 deaths, roughly. And that's just the picture of where we are. And for those of you who wonder about, accuracy, because there's definitely accuracy in terms of the death counts and with people getting, they died of COVID when they really died of something else and they just happen to have a positive culture. That's equally true the other way. So I think, again, the case counts are roughly accurate across the country and across the world. There's probably a little bit of difference here or there, but I can tell you people are dying in Oklahoma City from COVID as they are everywhere. So it's a real deal. Likewise, I want everyone to know that lots of doctors are talking all the time about what to do, at least in our community, trying to come out with some strategies. And I think the strategy that we need to all start focusing on as a medical community, not just here, but everywhere, which I'm starting to hear a little hoofbeats of, but really it's becoming a little more prevalent, especially amongst my friends, is we got to stop people from getting to the hospital. As I mentioned, an ER doctor said, very, very nicely that, you don't need to start anything, and if you fail and you come into the hospital, we'll treat you. The whole point is that's not the way to do it. That's reactive medicine. It's what I spent my last 20 of my 26 years in practice moving away from. I was trained as an OBGYN, so I delivered the baby. If someone had bleeding problems, I did the procedure to stop the bleeding problems. And that's kind of the problem with American medicine and medicine across the world, is we're reactive. We're trained to treat the problem. So the change we need to institute for COVID is, let's treat the problem and come up with normograms before someone's actually sick enough to go to the hospital, because there's going to be too many people at the rate we're going with these infections for the hospitals to handle it. When you go to the hospital, you can die, not because of the hospital, but you're so sick. Two, it's labor intensive. It costs tons of money. You get all kinds of big time drugs, some of which will kill you onto themselves. So it's a lot easier and safer to treat you before you get to the hospital. And I think that's the movement, and that's what I think our focus needs to be as physicians and PAs. But again, there's so much negativity for starting or initiating treatment. And again, there's no guidance from the federal government. There's no guidance from local authorities. There's no guidance from the NIH, CDC, or FDA. Thankfully, there's a really nice website one of my doctor friends, Bill Bondurant, sent to me, going over peer-reviewed journal articles and thoughts on how to treat patients. As I mentioned in this paper I've posted, there are 7 basic steps for outpatient COVID treatment that we really need to all adopt. And so that's where we have to switch the medical community and get medical systems to enable their providers to start treating patients on an outpatient basis, and err on the side of, hey, if I have 100 patients who get COVID and that are over 50, 20 to so are going to go to the hospital, I'm going to have to treat all of them initially to prevent 18 of the 20 to go. And getting that change in place with some simple maneuvers is what we need to do, because we have to stop the deluge of patients who go to the hospital. So we need to err on the side of caution. It's a philosophical difference perhaps that I have with others, but when you're looking at, if it's me, it's really simple. If I get COVID, I know I have a 20% of going to the hospital. I have half that, 10% of going to the intensive care unit, and 5% chance of dying. I would much rather not wait, as most people would rather not wait, and you give them the option, of course. Why not be treated on the off chance that you prevent that? And especially when the treatments are very safe to do. Plaquenil is very safe. Zinc is very safe. Elderberry is very safe. Multivitamins are very safe. Vitamin C is very safe. Melatonin is very safe because they're effective and meaningful for people. And so I think that's very important. And that's the big conundrum in medicine, is how do we enable doctors, providers of all types to actually initiate therapy without fear of reprisal, criticism, and lawsuits and humiliation. And that's the challenge, and I think that's what we're all trying to work on here, many of us in Oklahoma City, and I'm sure there are other physicians across the country who are doing that too. So that's the big update today, is we're working on trying to enable physicians locally, and really are going to start that process more tomorrow with some things we're doing to really push to get some organization to communication of, yes, you can do these things without so much fear of reprisal. And perhaps we need to get the state involved, get Governor Stitt involved. He has a lot on his plate right now, but by the same token, I know he's very interested in the COVID situation, and he has, again, bought a lot of hydroxychloroquine that's sitting safely at the state health department. So maybe we can get some help from the state. There's new people there. Again, the old people were great, but we have some very good new people at the state health department. So that's what we're going to be aiming for. There are a lot of people ask questions or send questions. So there's a few things I need everyone to not do. So if you have questions, I do my best to answer them online if you send them on YouTube or if you send them on Facebook. However, realistically, I'm really busy, and I actually do get pretty exhausted sometimes, and then I just don't look for a few days. So Monday, we're going to do a question and answer again. So, and if we want to do it, should we do it live like we did last time?
Yeah, sure.
Sure, we'll do it live, and let's shoot for
7.
How about 7:30?
7:30. Okay.
7:30 Central Time. We'll do a live Facebook, and if you can send in your questions, and I'll answer them then. What I don't need everyone to do. Lots and lots and lots of people are calling my office and want questions answered. We can't do that.
Well, the front girls.
The front girls don't know. The front ladies, who are wonderful, they don't know. And I'm in the middle of clinic, and we're not going to be answering questions. We have to take care of our patients that are there. So that will be a solution. Number two, if you want to make, and again, I want to emphasize that I have a very busy practice. I'm very full. I don't need any new patients. However, if you do want to have a new patient appointment with me because of COVID or some other reason, we're working on trying to figure out what to do with telemedicine. We had some information we couldn't do new patient visits on telemedicine. We're finding out that may have not been correct, and I don't know how we got the information we did. But since I had a new telemedicine patient visit as a patient with a provider yesterday, I was like, how can you do this on telemedicine and our office doesn't allow it? It didn't make sense to me. So we're researching that, and we may have a solution for new telemedicine visits in the next few days because we understand that's important. What else, hon?
Just you cannot prescribe Plaquenil to someone.
Oh, I can't give medical treatment to someone. I can't prescribe Plaquenil unless they're an established patient. So you have to establish as a patient either with myself or one of my providers. I have 6. Other people who work directly for me, who are all superb clinicians. Tina Telkachi's been with me 12 years, Abby Ronk, I think 11, Tricia Hall 8 or 9, 8, I think, or 9, Shannon 5. I know for them it's like dog years, so it's probably like 35 years for Shannon. And then Amy Brooks 3.5 or 4, and Bethany Cook about 2 years. So they're a very good group. We work very closely together. So and we're on the same page. So anyway, so you have to establish. So we're going to be working on new appointments and see if we can do something with telemed to get that taken care of. And just remember, your zinc matters. Elderberry. Oh, I was going to talk more about elderberry, but I will tomorrow. And I'll bring home a bag of stuff. I actually give people all the time if they're traveling. I just bought a few hundred of them and give them to people for travel. It's a Zion product, which is an elderberry zinc lozenge. I just ordered a couple hundred of them on Amazon and just keep them at the office. And if anyone's getting on an airplane that they tell me, I just give it to them and give them instructions on how to use it. And then, so we'll go over a little bit more about elderberry and why it works. If you look at the article about the 7 steps for COVID on an outpatient, there's an entire section on elderberry and goes through all the medical literature in exquisite detail. It's a great review for a nerd. So that's really what we're going to focus on more so over the next few days. Go ahead.
Okay, so you just had a few questions.
Sure.
That I think are
a couple more questions, I guess.
Yeah, I think you've gone over these in the past, but is Plaquenil safe if you're pregnant or nursing?
Plaquenil's not something you would use when you were pregnant or nursing. There's very limited data on people getting, or limited information, or limited cases of postpartum women getting sick. So again, not, I think, a huge concern, but again, I would definitely want you on your prenatal and start your zinc right away after delivery. And I think if you're on a prenatal, when you're pregnant, you're in pretty good shape. There was a recent report from the American College of OBGYN that perhaps there was a slight increased risk of illness, but that's just not played out so far that I've heard of, and there's no repetitive reports of that. So far, so good.
Okay, and then is zinc safe if you're pregnant or nursing?
Yeah, zinc's totally safe. I mean, I'd probably, because of stomach stuff and your own immune system, only do about 15 milligrams, because zinc is, as we've talked about many times, hard on the stomach, and when you're pregnant, we need to be gentle with the stomach. So 15 milligrams would be plenty for a pregnant woman.
Okay.
Or postpartum.
And then on zinc, how often can you do a pulse?
You can do a pulse twice a week. I mean, some people want to, if you just want to do pulses, you do a pulse of 150 to 200 milligrams on Sunday. Don't take any more till Wednesday or Thursday, and either Wednesday or Thursday do another pulse of 150. I think you can do that twice a week instead of taking it routinely through the week, and so you're surging up and coming down. And there's some data on why you would do that. Our research trial we're actually going to be moving forward with now, because with this wave, we were going to start our research trial on zinc. We thought in the fall, but since this pulse has turned into a full surge of COVID cases, we're to roll it out. And our actual protocol is 150 milligrams once a week. And if a person then has any signs or symptoms of cold or respiratory tract infection, and it's been more than, so if they're doing their pulse on Sunday or whatever day, and if it's Wednesday or day 3 after or later, you do the pulse again. So that's how we're going to do our study on zinc.
Okay. What do you?
But again, it's with food, lots of food. And again, we're splitting the dose, not all at once. It's 50 milligrams every hour to hour and a half, 2 hours to get to the 150 or the 200.
And if you still feel nauseous after taking it with food, then make sure you're not taking it with any other medication or something.
Yes, that's the other thing. Taking zinc with, like, at the same time, if you're on Plaquenil already and it's a little hard on your stomach, if you take zinc at the exact same time, we get a doubling effect. Just like if you're on any medicine that's hard on your stomach, adding zinc is going to make it worse. So just keep that in mind. Common sense, common sense.
Kids going to college, what do you suggest these younger kids, but
I think that I
on?
think college kids need to be on a small dose of zinc, and I'll map that out in more detail this weekend on one of my posts, because that's actually a separate it's a similar subject, but I think that takes a little more discussion.
Yeah. Okay. And then melatonin. Is there a pulse type thing that you do with melatonin?
Melatonin, I think you just take consistently 1 to 2 milligrams. Now, if you get COVID, I think going up to 5 to 10, doing more will not hurt you, and it could have some potential salutary effects, lessening effects of inflammation. So, but if your baseline is 1 to 2, your inflammatory pathways are turned down.
Okay.
Okay, good night. Thank you for your time and patience, and have a wonderful weekend. I'll be posting over the weekend, and I'll promise to discuss elderberry in more detail and getting ready for school.